Welcome back, guys. My today's lesson is one of the most common pediatric dermatologic problem about impetigo. Just to start from etiology and the pathogenesis, impetigo is the most common skin infection in children throughout the world. And there are two classic forms of impetigo. Those are non-bullous and the bullous type. Non-bullous impetigo is predominantly caused by Staphylococcus, whereas some lesions of non-bullous impetigo can be caused by group A beta hemolytic streptococcus. Staphylococcus generally spreads from the nose to normal skin and then infects the skin. In contrast, the skin becomes colonized with group A beta hemolytic streptococcus an average of 10 days before development of impetigo. Lesions of non-bullous impetigo that grow Staphylococcus in culture cannot be distinguished clinically from those that grow pure cultures of group A beta hemolytic streptococcus. When we see bullous impetigo, unlike that of non-bullous impetigo, bullous impetigo is always caused by Staphylococcus, a strain that produces exfoliative toxins. The staphylococcal exfoliative toxins A, B, and D blister the superficial epidermis by hydrolyzing human desmogellin 1, resulting in a subcorneal vesicle. When we see the clinical manifestation of impetigo, non-bullous impetigo accounts for more than 70% of cases, whereas the bullous types of impetigo is responsible for around 30% of cases. In the case of non-bullous impetigo, lesions typically begin on the skin of the face or on extremities that have been traumatized. And the most common lesions that precede non-bullous impetigo, or the most common lesions that cause trauma to the skin and predisposes a child for non-bullous impetigo include insect bites, abrasions, laceration, chickenpox, scabies, and burns. A tiny vesicles or pustules forms initially and rapidly develop into honey-colored crusted plaque that is generally less than 2 cm in diameter. The infection may spread to other parts of the body by the fingers, clothing, and the towels. Lesions are associated with little to no pain or surrounding erythema, and the constitutional symptoms are generally absent. Pruritus occurs occasionally, whereas regional adenopathy is found in up to 90% of cases, and the leukocytosis is seen in around approximately 50% of cases. This is an image of a child having non-bullous impetigo. So it is, as you see on the image, it is a honey-colored crusted plaque. The next one is a bullous impetigo. Bullous impetigo is mainly an infection of infants and young children. In this case, a flaccid, transparent bullae develop most commonly on the skin of the face, buttocks, trunk, perineum, and extremities. Neonatal bullous impetigo can begin in the diaper area, and the rupture of a bullae occurs easily, leaving a narrow rim of scale at the edge of the shallow and the moist region. Surrounding erythema and the lesional adenopathy are generally absent. Unlike those of non-bullous impetigo, lesions of bullous impetigo are a manifestation of localized staphylococcal scalded skin syndrome, and they develop on intact skin, whereas non-bullous impetigo is mostly developed on traumatized skin. This is an image of a child having a bullous impetigo. So it is a transparent bullae that easily ruptures and leaves a scar. When we see the complication of impetigo, bacteremia with subsequent osteomyelitis, septic arthritis, pneumonia, and septicemia may appear in the case of both bullous and non-bullous impetigo. And also cellulitis has been reported in up to 10% of patients with non-bullous impetigo and rarely follows the bullous form. Infection with nephrogenic strains of group A beta hemolytic streptococcus may result in acute post-streptococcal glomerulonephritis. The clinical character of impetigo lesions does not predict the development of post-streptococcal glomerulonephritis. Regarding treatment of impetigo, the decision on how to treat impetigo depends on the number of lesions and their location. Topical therapy for impetigo for 10 to 14 days is acceptable for localized disease caused by Staphylococcus, and systemic therapy with oral antibiotics for 7 to 10 days should be prescribed for patients with streptococcal or widespread involvement of staphylococcal infections. So when etiology is streptococcal, always we should have to prescribe oral antibiotics, whereas if it is Staphylococcus, for localized one we can give a topical one, and for widespread involvement of the body due to staphylococcal, we should have to prescribe oral antibiotics. When lesions are near the mouth, where topical medications might be leaked off, we should have to also prescribe oral antibiotics. And also in cases with evidence of deep involvement, including cellulitis, furunculosis, abscess formation, and suppurative lymphadenitis, oral antibiotic for 7 to 10 days should be prescribed. When we see the drugs that is used to treat impetigo, for topical one, mupirocin 2% ointment can be used for 7 to 10 days. And for systemic one, we can use amoxicillin clavulanic acid, cefroxime, cephalexin, and also other drugs. Thank you for listening. Have a nice time.